Let me first say, we survived without an acronym. We never did an acronym. But if we had done an acronym, I think it would be NCQA Channel PO. Now, nobody would ever figure out what that meant, but NCQA Channel PO, what do you think? I should have made you look at this. You would have figured out something cute. So first I want to say, that there are two elements in any hypothesis about the link between nursing care and clinical outcomes. The independent variable, how the nursing input is measured, and the dependent variable, whatever clinical results you choose to measure. We chose, in terms of an independent variable, to use direct care nursing hours. It's been shown by multiple other studies that there's an association between RN staffing and Joint Commission measures, in some cases HAPU measures, and JCAHO recently sort of scooped us by showing that there are patient experience measures that are also related to nurse staffing. But all of these studies used huge administrative data sets to determine nursing inputs, which includes supervisory people, includes nurse educators. It does not focus directly on direct care nursing staff. So we chose to use the ANA and NQF endorsed direct care nurse staffing data collected at the unit level. Thanks to Nancy Donaldson and Carolyn Aden and Mary Foley, we were able to acquire the CalNOC data set for this unit level nursing, and it was separated by medical and surgical. Didn't turn out to be much of a difference, but we tried to see if that made a difference. We couldn't go really to the unit level in our analyses because JCAHO doesn't come in at unit level. So we ended up having to stay at that level. We chose nursing sensitive national performance metrics for our dependent variables from the Joint Commission, but we chose more nursing focused measures. We didn't use them all. And with CAPS, we also used more nursing focused questions. We didn't include, for example, satisfaction or communication with doctors. We included communication with nurses. And in California, we have 9 additional questions that we use, which you will see later were very important. We also looked at hospital-acquired pressure ulcers as another dependent variable. Data analysis, here's the fine print. You can read it. We did correlational analyses, we did regression analyses, and we got some good data. Results. Basically, we found that RN direct care hours per patient day were significantly positively associated with the percentage of patients receiving beta blockers on arrival for AMI as a JCAHO measure, and percentage of patients receiving pneumonia, sort of the composite package of pneumonia prevention, including vaccine. Otherwise, the things that we found were all CAPS, hospital survey, or HCAPS items. HCAPS overall rating and would recommend were strongly and significantly correlated positively for RNs. Courtesy and respect from nurses listening to you, pain control, help with pain, medications. We saw the purpose of medications and side effects of medications. Patients said they really got it. They were given this information by nurses. And then after discharge, patients responded that they felt that they had gotten the help that they needed to understand what they would need when they go home, as well as that they were explained the medications that they need to take home that were new to them. These are very important patient safety pieces. And this is coming from sort of the horse's mouth. This is the patient. It's not a nurse checking the box saying, I gave this information. It's the patient saying, I got it. I understand. I really did get the information I need. So there's a lot of question about whether patients really know what they have anything to do with quality, but I think this is a very important piece to look at and recognize that this is a very important data to understand and to respect. The RN hours per patient day really had no significant relationship to hospital-acquired pressure ulcers. It was positive but not significant. And LVN staffing data showed the opposite association in virtually every measure, where we saw that RNs were significantly positively correlated with better outcomes, LVNs. The moment an LVN was put into the mix, it went south. Very interesting stuff. I just did a quick diagram to sort of show you here. Here is the bottom quartile on the HCAHPs of would recommend. This means that if we only had 54% of the patients in their hospital saying that they would recommend the hospital to their family and friends. The mean RNA-HPV here is 5.98 with 0.70 LVNs or 10% LVNs. The highest quartile, where the mean of 79.3 said that they would recommend the hospital to family and friends. We had a 6.53 on mean RN. I was with patient there. Our range went from 3 to 10 on these RN application beds. Mean LVN 0.20, 3%. So the minute that you put LVN hours in here, you begin to see declines in performance on the HCAHPs. Interesting stuff. Sort of surprises. I'm not sure it's the LVN's fault. It's clearly a substitution piece, but it could be that it happens to be a for-profit hospital. They have other sort of issues. We don't know the answer to that, but it's important data to look into. Unlicensed personnel, really the only significant thing we saw was that as we have more AIDS, there's more in smoking cessation advice and counseling. Maybe because RNs have more time, that measure is sort of gone anyway. So basically, there's strong and significant associations in the study between increased RN staffing and patient satisfaction and rating of hospitals. Last year, we did a study where we looked at the HCAHPs sort of methodologically, and we found that the RN pieces, the nursing communication pieces, are what drive the CAHPS survey. In other words, if nothing else, but nursing, let me say this differently. If, in fact, you look at the CAHPS survey and the questions, the nursing questions that respond to nursing communication account for the largest amount of variance of any piece in the survey. Nursing drives HCAHPS. Maybe nursing care is HCAHPS. This further validates work that's been done prior to this time using larger data sets. However, we see now that direct care with patients on board in the units significantly is associated with RN staffing. So higher levels of RN unit staffing improve hospital performance. Patients are more satisfied with their hospital experience and rate hospitals higher as RN staffing increases. So basically, the question is, are there increases in nurse staffing with some JCAHO measures? Yes, but really just beta blocker and arrival. That's really an ED measure anyway. Not sure what that really means. Pneumonia prevention, pneumonia vaccine, those are all very high and almost sort of topped out measures anyway. I'm not quite sure what those mean. So I don't feel like there's a lot of bounce on this. However, other people have seen that nurse staffing is related to overall performance when you look at the huge sets. Question 2 is more significant for us, and that's in terms of the nurse staffing increases in skill mix associated with improved patient perceptions of nursing performance as reported by the CAHPS. And yes, again, positively for RNs and negatively for LVNs, and significantly on communication with nurses, help with pain and pain control, which we've talked about before. So, why it's important. They're probably the only available outcome measure of patient satisfaction with the care and information that was actually provided. Strong findings linking increased RN direct care unit staffing to higher hospital performance further validates similar findings that we found with total RN staffing. These data suggest the use of higher LVN staffing, often considered a substitution of RN staff, is negatively associated with patient satisfaction and hospital rating. Hospitals are increasingly interested in scoring higher than competitors and pay for performance rewards.